Okay, so we didn't do the assessment of index of myocardial index of myocardial performance on Thursday because we want to spend a little bit more time uh, so we understand it uh, fully. Uh, One of the methods to assess RV function, and this is not systolic function now, this is RV function, overall function, is the index of myocardial performance, IMP. You can do it for the right side and you can do it for the left side. When we do it for the right side, we call it RIMP, okay? So that's right ventricular index of myocardial performance, RIMP. It's also called the TIE index. And for those of you who are doing exams, okay, at least you need to know, have an idea what it is because they will bring something, not anything in depth or detail, but you need to have an idea what it is. Okay, so again, you can do it for the right side and you can do it for the left side. RIMP, it's an assessment of the overall function. So how do we calculate RIMP? If you look on top here, okay, you see we have, this is a RV inflow pattern and we have another RV inflow pattern. And then if you look below, you see there is ejection across the pulmonary valve. So you have to do two assessment, and you can use either your Doppler to do it, or you can, well, they're both Doppler techniques, but you can do tissue Doppler, or you can use your mitral inflow and your RV outflow together. It's a little bit easier if you do your RV inflow and the right ventricular flow track uh, Doppler separate. So basically, what we're doing is you put your cursor across the tricuspid valve and you get a tricuspid inflow. Okay, so the definition of RIMP is what you're gonna do. You're gonna get the duration. So this is a time event now. It is the duration from tricuspid valve closure to tricuspid valve opening. You're going to subtract from that the ejection time. So, all right, so just conceptualize it a little bit. So the tricuspid valve close and then it open, right? It does that. It opens to allow blood to flow from the right atrium to the RV. At the end of diastole, the tricuspid valve close, and then when diastole starts again, it opens. So RIMP is the duration from tricuspid valve closure to tricuspid valve closure to tricuspid valve opening. You're going to subtract from that the ejection period. When we talk about ejection period, when the pulmonary valve opens, blood is going to be ejected, and it's going to be ejected for a period of time. So it has a definite period over which you're going to get ejection. And then so the pulmonary valve opens, blood is ejected. At the end of that ejection period, the pulmonary valve closes. So that is what we call the ejection period. So the definition for RIMP is from tricuspid valve closure to tricuspid valve opening. You're going to subtract from that the ejection period, and then you're going to divide by your ejection period. That is the definition for REM. Tricuspid valve closure to tricuspid valve opening, you subtract from that the ejection period, and you're going to divide by the ejection period. So essentially what you need to make that calculation is your RV inflow. So this is your RV inflow. So now the RV inflow. So this is when the tricuspid valve opens, you're gonna get suction of blood giving your E velocity. Then the atrium contracts, you have an A velocity, then tricuspid valve close. Then blood in the RV is going to be ejected across the pulmonary valve, and then you have your tricuspid valve opening again, E velocity, A velocity. Remember that and the same thing happens on the left side with the mitral valve. When the tricuspid valve closes, that represents the end of diastole. You don't just go into systole. There's what we call IVCT, isovolumic contraction time. Okay, so all the valves are closed. The mitral valve, sorry, the tricuspid valve, we're on the right side. So the tricuspid valve and the pulmonary valve are closed. So the valves are closed. It's the first portion of systole, but your pulmonary valve is not yet open. Then after your IVCT, isovolumic contraction time, after your IVCT, then the pulmonary valve opens and you have ejection across the pulmonary valve into the pulmonary trunk. Then the pulmonary valve closes. You don't just go into the mitral valve opening, the pulmonary valve, sorry, tricuspid valve opening. You don't just go into tricuspid valve opening. When the pulmonary valve is closed, there's a little time before the tricuspid valve opens. And this is what you call your IVRT, isovolumic relaxation time or period. Then the tricuspid valve opens. Then you get your E velocity and your A velocity. Okay? So this is your IVCT and this is your IVRT. So remember, what's the definition of RIMP? It is from tricuspid valve closure to tricuspid valve opening minus the ejection period divided by the ejection period. So if you're going to subtract ejection period from tricuspid valve closure, tricuspid valve opening, you're going to be left with IVCT and IVRT. So you can also rewrite the equation as IVCT plus IVRT divided by ejection period. And if you look down here, that's exactly what they didn't do. But anyway, the definition for RIMP is tricuspid valve closure to tricuspid valve opening minus the ejection time divided by the ejection time. And you can simplify that by just having IVCT plus IVRT divided by ejection period. Because this first period right here is IVCT. This second period is IVRT. If you subtract ejection time from everything up here, all you're going to be left with is the first portion and the last portion, which is IVCT and IVRT. So this shows you that RIMP, which is assessment of RV systolic function, IVCT plus IVRT over ejection period. When you have systolic RV systolic dysfunction, if the RIMP is greater than 0.4, then you can make that assessment that you have some dysfunction in the RV. Okay, in research centers, they tend to use this more. Okay, so you have to know the different components that make up RIMP. You have to have an understanding uh, how to get it. The other name for it is the tie index. Okay, so on the exam, they might just ask you, what is tie index? So you don't have to know any details, but you have to, you know, appreciate how you get it, RIMP, and the basic definition. Okay, all right. So we went over this. Okay, so we look at fractional area change. Okay, so especially for people who are doing exams, you need to you need to have the again of a fair understanding of the tie index. Now, the other thing we gonna talk about is the IVC. Remember, your inferior vena cava drains into the right atrium, and the size will varies with respiration. Okay, with inspiration, you expect to get collapse or decrease in the size, and with expiration, it's going to increase. For a normal individual, you expect that inspiratory collapse to be more than 50%. You're supposed to almost get complete collapse with inspiration. And that's not going to occur if the pressure on the right side is elevated, your pulmonary pressures. So if your pulmonary pressures are elevated, you're going to not get significant collapse with inspiration. And when you're doing the test, you probably should do, so they actually talk about sniff. So you should let the patient sort of rapidly take a breath in, okay? And so we use it to help us to assess um, the right atrial pressure and ends RV and PA pressures. Okay, so that's one of the things that we use RVs the IVC size to do. So the right atrial pressure most commonly estimated by using the inferior vena cava diameter, and we're going to do the subcostal view to look at the IVC and whether there's inspiratory collapse, yes or no. Because if you remember, one of the important things, especially when you're talking about tamponade and constrictive pericarditis, is the size of the IVC. Because if it's enlarged and not collapsing, it's telling you that you have significant right atrial pressure. So you're going to measure the IVC at the end of expiration, and you should do these measurements just proximal to the junction with the hepatic vein. So just before you get to the hepatic vein, that's where you're going to measure. And at the end of expiration, um, you should put your M mode because you can see collapse fairly well if you do your M mode measurements of the IVC. So I recommend that you do that to quickly see if there's more than 50% collapse with inspiration. So the IVC uh, is going to undergo change in the size with respiration, and you get IVC collapse with the sniff. Okay, that which is just a rapid inspiration. So this is what we're talking about. So if your hepatic vein comes in right here, you just proximal to that, and it's done in expiration. Okay, so you're gonna measure it. Sometimes you're not gonna see a very nice IVC like this. You should um, you should use your M mode. Okay, so the measurement of the IVC, the diameter, which is the solid line, is measured perpendicular to the long axis of the IVC at end expiration. Okay, just proximal to the junction of the hepatic vein that lies about 0.5 to 3 centimeter proximal to the ostium of the right atrium. Okay, so this is your hepatic vein right there. Okay, so proper measurement is important, and again, try and use the M mode. So these are the numbers that you need to know. So for a normal IVC, that is estimation of the RA pressure on the basis of the IVC diameter and collapse. For a normal, if the IVC is completely normal, then the right atrial pressure is between 0 and 5 millimeters. And we just average it and say 3 millimeters. So a normal IVC, the diameter is less than or equal to 2.1 centimeter. And you get, with the sniff or inspiration, you get more than 50% collapse. Okay? These are the numbers that you need to know, not only for exam, but for your daily studies. The diameter should be less than or equal to 2.1 centimeter. And with the sniff or with inspiration, you get more than 50% collapse. The diameter decreased by more than 50%. Your right atrial pressure will be 15 millimeters mercury or greater if the IVC measures more than 2.1 centimeter. If you get less than 50% collapse with sniff, and also if you have restrictive filling, remember what your restrictive filling is greater than A by more than 2. If you look at your tricuspid and your EE prime is greater than 6, and then if you look at your hepatic vein, if you have diastolic flow predominance, this also suggests that the right atrial pressure is 15 millimeters of mercury or more. Okay? Restrictive filling, tricuspid EE prime greater than 6, and then in the hepatic vein, if you have diastolic flow predominance. Okay. So, how do we determine the pulmonary pressures? Because remember, measurement of pulmonary pressures is very important because it's going to tell you if the patient have pulmonary hypertension and then how significant the pulmonary hypertension is. All right, so we can measure the pulmonary arterial systolic pressure, which is going to be the same thing as the right ventricular systolic pressure, as long as there's no RV outflow tract obstruction. Okay, so the pulmonary arterial systolic pressure is usually equal to the RV systolic pressure unless there's an obstruction at the right ventricular flow tract or pulmonary valve level. They are the same, usually. So what we do, we use the tricuspid regurgitant Doppler signal, and that's going to represent the systolic difference. So remember again, when we say you have tricuspid regurgitation, in essence, what we're saying is that there's a pressure difference across the tricuspid valve in systole, where the RV systolic pressure is greater than the RA systolic pressure. That is why you have blood flowing from the RV into the right atrium. And then that TR velocity gives us the gradient. And the gradient is RV systolic pressure minus RA systolic pressure. That's equal to the gradient. And then once we rearrange our equation, so again, the gradient is equal to RV systolic pressure minus RA systolic pressure. once you rearrange your equation, then the RV systolic pressure is equal to the gradient plus the right atrial pressure. And the gradient from the modified Bernoulli equation, the gradient is 4v squared, where v is the peak TR velocity. So we squared the velocity multiplied by 4, and then we have the right atrial pressure. We went over how to get the right atrial pressure. If you have a normal RVC, if the RVC is normal, you're going to have 3 for right atrial pressure. If the IVC is more than 2.1 centimeter, less than 50% inspiratory collapse, and all the other stuff that we mentioned, they had 15. So RA pressure is 15. So you add 15 to that. And you get your right ventricular systolic pressure, which is the same thing as your PA systolic pressure, unless unless you have obstruction at the right ventricular flow tract or the pulmonary valve level, then that equality it no longer exists. So again, because it's a Doppler technique, you're going to use multiple acoustic windows to look at your TR jet. You're going to look at your apical four-chamber view, your right ventricular inflow view, the short axis at the level of the aortic valve, and you just get your TR. So multiple views, multiple acoustic windows. This is a Doppler technique, subject to the angle of the thing. So this is short axis at the level of the aorta. Tricuspid valve is over there, and your cursor is across the tricuspid valve, and you get your TR. Okay, the peak TR velocity here is 2.89. Square it, multiply by 4, the gradient is 33.5. So all you have to do to get the pressure now is to add, you're gonna add the right atrial pressure. So you're gonna add the right atrial pressure to this, and that's gonna give you your RV systolic pressure. And your PA systolic pressure. Now to get your diastolic pressure, so again, when we did hemodynamics, we went over this. To get your PA diastolic pressure, we just look at diastole, and you need to have PI, pulmonic insufficiency, to do this. So with pulmonic insufficiency, you have blood flowing from the pulmonary trunk across the pulmonary valve into the right ventricular flow tract. The only reason why that is occurring, again, is because the PA diastolic pressure is greater than the RVOT diastolic pressures, and that difference is the gradient. So the gradient is equal to the pulmonary artery diastolic pressure minus right. So the right atrial pressure is the same thing as your RVOT diastolic pressure, and that's why we have it there. It's the same thing. So rearranging the equation, your pulmonary artery diastolic pressure is equal to the gradient plus the right atrial pressure. And we just went over how to assess right atrial pressure. So, okay, again, remembering that the gradient is equal to 4v squared. The velocity that we're talking about, however, is your end diastolic pulmonary regurgitation velocity. So this is the velocity. So this is your PI. This is your PI, as we have shown. This is pulmonic insufficiency. And you have a early velocity and a late velocity. All right, and this is the velocity we're talking about, okay? So not the early velocity, late velocity. So this is the Doppler signal across when you have a PI. Okay, so you have one velocity there, another velocity there. We're going to use the end diastolic velocity. We're going to square it, multiply by 4, and that's a gradient we're talking about. You also have an early pulmonary regurgitation velocity. We're not talking about that one. Okay. There are other. Now the mean PA pressure is much more accurate than the other PA pressures, and if you look up the definition for pulmonary hypertension, most reputable texts will talk about mean PA pressure, not the systolic or diastolic pressure. But you can get the mean PA pressure by using 1/3 the systolic pressure plus 2/3 the diastolic pressure. So once you calculate your systolic PA pressure and your diastolic PA pressure, the mean PA pressure is 1/3 systolic plus 2/3 diastolic. Or you can calculate it directly by using the early PR velocity. So remember, we show you this. So if you use this velocity, square it, multiply by 4, you'll get the mean uh, uh, PR. Sorry, no, you're not going to, no. To get the mean PA pressure, you will have to use your, you're going to have to use your TR. Okay, what you do is, all right, so you can, if you want to mean PA pressure, then all you do you you use the early velocity, and then you that this is the mean PA pressure now. The mean PA pressure. Use the early velocity. You square it, multiply by 4, then you have the right atrial pressure. Okay. The other way you can do it is 1/3 the PA systolic plus 2/3 the PA diastolic. Or you can use just, if you're PR, you can use the early velocity, squared multiply and get that. Okay. So again, that is your mean PA pressure. And when you look for the definition of pulmonary hypertension, it's the mean PA pressures. Okay. All right. So we're going to stop here, and